The two main types of RET gene alterations are point mutations, which we don't usually see as commonly in non-small cell lung cancer. We see it more commonly in thyroid cancers. And there are the RET rearrangements or fusions that we see more commonly in non-small cell lung cancer. These occur in about 1 to 2% of non-small cell lung cancer patients. Usually the person who presents with these RET rearrangements is somebody who is on the younger end of the spectrum. There are patients who have no history of smoking, and the most common subtype of non-small cell lung cancer that we see these rearrangements in is adenocarcinoma. These appear to be associated with a high risk of metastasis to the brain, and this correlates with a lot of other subtypes of mutation-driven lung cancers. We see that across the spectrum of this group of non-small cell lung cancers. The fusion partners, the ones that we usually see are the KIF5B. This is the most commonly seen partner to RET, and it occurs in about 70 to 90% of tumors. And then the other less commonly seen is the CCD6 RET fusion, and it's seen at about 10 to 25% of tumors. There are other partners that we see, but to a much lesser extent as a partner for RET. How do we look for these rearrangements? One of the older ways of looking at them is fluorescence in situ hybridization. You can also hear your physicians and healthcare team talk about something called FISH. What this really means is that we are technically staining different genes and looking at them under the microscope. This is a picture demonstrating how this looks under the microscope in a different fusion gene that we see in leukemias, but it's a helpful illustration. So on the left side, on the normal cell, you would see two different copies of two genes. I'm going to call them the red gene and the yellow gene. And then in the cancer cell, which is on the right side, you can see that you have two copies where the red and the yellow genes are fused to each other. This is what we call a fusion. That was the older way of looking at fusions, and usually we still use it in situations where we have limited tissue, for example. The more advanced and the more widely used way to look at rearrangements is what we call next generation sequencing. That usually uses the patient's tissue. We use a machine in order to do this sequencing of the DNA in the tumor cells, and that gives us information on multiple mutations or biomarkers at the same time. Often we use this to look at large panels of genes, and sometimes we can even look at the whole DNA inside that tumor cell. Another way that was very eloquently illustrated by Dr. Luo is the liquid biopsy or the blood-based testing that looks at the alterations in what we call the circulating tumor DNA, where we isolate that DNA from the circulation that's being shed by cancer cells, and we look at them and sequence that in order to identify the fusions.